Hi, everyone. This meeting is being recorded. You guys will probably have a consent that'll pop up. Please consent to that. This will be recorded for everyone. Again, my name is Lauren Williams. I'm the NeuroTrauma Program Coordinator. So I work under Trauma Services. And here I'll give you a little bit of a disclosure and introduction. The cornerstone of every trauma program is really performance improvement. So as we are doing this case review, I want everyone to know these are non-punitive reviews. We're really looking for how can we change the system? How can we provide safe patient care, change our culture and our environment? So I do not have anything financial to disclose here. And as Fran said, we will be discussing a case that actually did come through our ED and ICU. So the meeting is confidential. There are no patient identifiers, so it can be recorded, which Fran will be doing. Some things that we'll go over throughout this case review. For those of you who have taken TNCC, you may see some of those clinical points sprinkled into here. And then also throughout the presentation, you'll see some of our BCH-Oakland specific TBI guidelines as it relates to the case. We'll go through the case, and then after we will discuss what did we learn and what can we do differently next time. So I always like to start off any sort of neurotrauma lecture pretty basic with, I'm sure you guys have all seen this, it's the Monroe Doctrine, which basically says that your brain is a defined space. The volume inside of there is fixed. So as any one component goes up, the other ones must decrease in order to compensate inside of this space. So you have your brain matter, you have your blood, and then you have your CSF. And this doctrine will kind of continue throughout this whole lecture. So when we think about head trauma, what does that mean? You actually result in brain dysfunction. Sometimes that can be temporary. Sometimes in more severe cases, you'll actually see that that becomes more permanent brain dysfunction. Ultimately, you know, the worst kind of brain dysfunction is obviously brain death, which TBIs can go to if left untreated or if it's just really severe. So what kind of head traumas do we see? Blunt impact. The top cases for neurotrauma are falls and motor vehicle collisions. So there you probably have the blunt impact. Penetrating injury, we think about gunshot wounds, stab wounds, also possibly shrapnels if you're in a motor vehicle collision. You can get some of those. Blast waves. In my career, I've not seen a blast wave neurotrauma, but maybe some of you have. And then this accelerating, decelerating force, also called the coup contra coup, where you have this brain shaking around in the space. So you can actually have injury in the front half of the brain, back half of the brain as well. So primary injuries, and again, primary meaning these are what's occurring at the time of the injury. This is your initial mechanism. What can this result in? We've seen skull fractures. Sometimes if those skull fractures are non-complex, if they're just linear, some of you may have seen that patients can actually go home with a skull fracture if there's no intracranial process. More worrisome are these blood vessel injuries, and that's when you actually have bleeding inside the brain. So you can see the types there. I'm sure you guys have heard of an epidural or a subdural, a subarachnoid, or a hemorrhage within the cerebrum. Also, you can have brain parenchyma injuries, and these are your brain contusions. Also with that coup contra coup, you can have some shearing of the axons, which can lead to diffuse axonal injury. Now, these don't have to live isolated from one another. Sometimes you can have a patient who has all three. Maybe they have contusion somewhere, they have DAI, they also have a bleed, and they also have a skull fracture. Those are typically a bit more severe. So what is our goal in primary injuries? Our goal is to prevent them. And this is where our injury prevention team really does a lot of work. Once they're in the hospital, what we are doing is preventing secondary injury. So to prevent primary injury, this is where we are giving out car seats, where we're educating on the use of helmets, where we're using window locks. So primary injuries you want to prevent. Once they get to us as the bedside nurse, what we are doing, our whole goal is to prevent secondary injury. And as you can see over there, a lot of secondary injury comes from that increased intracranial pressure, like we talked about in that Monroe-Kelly doctrine, is where you just have too much in the brain space. It has to go somewhere. It can lead to cerebral herniation. Also, an excitable brain can also be prone to seizures. Not every case, not every TBI does have seizures though. Also, given that we all work in pediatrics, I just want to make a note that it takes a lot of force to cause a traumatic brain injury. So when we see patients who are not yet mobile, not yet ambulating, and they come in with a head injury, it's not certain, but we should always be mindful of non-accidental trauma. This is a really busy slide, so I apologize. But as we talked about with primary injuries, what do? We prevent them. And the number one trigger for shaken baby syndrome is frustration. A caregiver is frustrated, and this can happen. We saw an increase in child abuse during the pandemic because, again, there's a lot of stressors. So when you think about the anatomy of a child, their head is really large in comparison to the rest of their body. They also have weak necks. So when we see infants with head injury, we also do have to worry about if there's any cervical spine injury. So again, you see in this top picture that you see that kind of coup contra coup injury where they can end up with brain bleeds, so a subdural hematoma. This is where we also get ophtho involved, because actually with this shaking movement, you can have the retina detach. So we are looking for retinal hemorrhages inside of the eye. And lastly, like we talked about, because they have these weak necks, you're worried about spinal injury. So make sure you get these kids or these infants in collars. All right, so we know our biggest thing is to prevent increased ICP. So what are some early signs that we may see? Nausea and vomiting is one of the earlier ones that you'll see. And as you can see over there, be mindful if you are requiring Zofran to keep them comfortable. We'll talk about our policy on that, but there is a potential that you can be masking symptoms in the TBI patient if they are requiring pretty frequent Zofran. Altered level of consciousness, and this can present itself in a myriad of different ways. Sometimes impaired judgment. You have the patient who's in the ED or the ICU, and suddenly they're impulsive or they're just not acting like themselves. I'm sure you guys have all seen someone who's restless or someone who's drowsy. Maybe you need to shake them to get them to respond to you. So these are all earlier signs.
Right.
What is it? As well as headache or amnesia. Post-traumatic or amnesia is fairly common amongst TBI, and it doesn't necessarily have an indication of how severe the TBI will be. In regards to headache and pain, we do want to avoid the use of NSAIDs. There is a potential for bleeding with the use of NSAIDs. This research, I will admit, is a little bit controversial. It's not totally known whether or not this causes it, but our policy is that we avoid NSAIDs for 48 hours, especially if we're not getting imaging, because we don't know if there's any intracranial process there. We don't know if they're bleeding. And actually in concussion patients, in some, it's either mice or rat studies, they've actually shown that it can contribute to microvascular changes that you may not even see on imaging. So to be safe, we do say avoid NSAIDs for 48 hours in the unimaged patient. But once you have a bleed that's confirmed, you'll probably stay off of NSAIDs for a little bit longer. Okay. And what are our late signs? These are worrisome. These are not great signs. The dilated non-reactive pupils. I'm sure this is probably what everyone thinks with the severe TBI. This is what you don't want to see. And this is why we really advocate for doing pupillary exams with every neuro check. Next is the Cushing's response, or the Cushing's triad. This is where you're going to see that bradycardia and hypertension with the widened pulse pressure. You will see some decreased respiratory effort. You may also see those Kussmaul's respirations. Posturing is whether they're bringing their hands inward or outward with pain or at rest. And then obviously unresponsiveness. They're not responding to you when you're applying verbal or painful stimuli. So these are more late signs that you'll see. Okay, now let's get into our case. So this is a 12-year-old male. He's got a GCS of 15 and he has no past medical history. So fairly healthy kid. Then takes a baseball to the side of the head. So he's struck in the head by a baseball around 1 in the afternoon. He does not lose consciousness, but he does have lethargy. And while his mom is driving him to the ED, he starts to feel nauseous. So here is where I would have put my poll up, but I don't have the polling feature right now, so I apologize for that. So can anyone in the ED tell me, just with this very, very small pre-hospital information, what are you worried about? And I gave options, so I'll give you guys options as well. It was, are you worried about the lethargy most? Are you worried about the nausea? Are you worried about the mechanism? Or maybe you're not worried at all. You think this kid might be fine. Can anyone tell me what they're worried about? Any ED nurse?
Are all muted.
All right, Fran, can you call on someone? I don't know who the ED nurses are. We just want to know what we're concerned about. We have a strike to the head, lethargy, and nausea.
How about you, Marie?
I'm worried about the nausea and the lethargy both together.
Yeah. And I would say I am a little bit worried. Absolutely. Yes. Worried about the lethargy, the nausea. I would say I'm a little bit worried about the mechanism too. When we think about concentrated energy, if someone were to walk into a door, you may not have any sort of effects from that. But given that this is a small object hitting him right in the side, you worry about all of that energy kind of being concentrated in one area, which you guys may remember from TNCC. All right, so he comes to our ED, 14:47, an hour and a half after. And then he waits, and triage doesn't begin until 30 minutes after he arrives. And now he has some swelling to the right side of his head. His heart rate is 76, respirations are 18, blood pressure a little bit elevated at 122/70. His pain is pretty significant, 7 out of 10 pain. Okay, so what is your game plan? And again, this was going to be another poll, so I apologize. If another ED nurse can tell me, would you guys activate this patient, or maybe let's continue triaging and assessing? And if you would activate, would it be a full, would it be a partial, would it be a consult, or would we just continue with triage?
And Lauren, people are writing in the chat, so.
Oh, okay.
So
Can you?
come on, ED people.
Oh, yeah, thank you. Thank you guys for all putting in the chat. Okay, so Emily says CT, consult, a charge, or attending for need for trauma activation. Awesome. Okay.
Come on, you charge nurses. What would you call?
Partial trauma.
All right. So let's see, what do we do? And someone says trauma activation, absolutely. Okay, so awesome. Thank you guys. So we're looking at the activation criteria. Starting from the right side, we see the trauma consult. This is a minor injury. This is someone you think they're going to get admitted, but right now they're looking pretty stable. Okay. In the partial, this is a major injury, and you may think that they may need trauma surgery evaluation. You really want trauma to come and take a look at these kids. Otherwise, trauma full, that's your level 1. I'm sure you guys are all familiar with all of these levels, but trauma full, this is when you're thinking, okay, this is a major injury. This kid is unstable. We're going to have to do something soon. This kid's going to need a lot of interventions. So for this kid, I would say trauma, I see kind of the points for all of them, but starting from the right side. So yes, we have a closed head injury. He did not lose consciousness, but he is still having that lethargy and the nausea. And I put it as a dotted line. I don't think he's here yet. I don't think he's a deteriorating GCS, but I wanted you guys to be mindful of these kind of categories throughout for just a TBI patient. The other thing I want to highlight is in a full, if you're considering that this patient is going to need emergent surgery. As you guys know, a trauma full is the best way to get all of your resources in one place. It gets you anesthesia, it gets your OR prepared. So if you are thinking that this kid's going to need emergent surgery, call a trauma full. So let's see what happens to our case. Yes, and as Jackie said in the chat, partial activations can be based on high energy mechanism. So as we know, this kid pretty concentrated, got hit with this baseball, and fulls are about physiologic abnormalities. Yeah, so looking at the clinical presentation. All right, so this kid gets Tylenol. Why didn't we give him ibuprofen? He's got a 7 out of 10 pain. We just talked about this. So reason why we don't give ibuprofen is because we don't yet know if he's bleeding, and we don't want to exacerbate anything without knowing what's going on inside of the brain. And here, if you were to refer to our mild TBI guidelines, that I'm sure you guys all love to read. It's like a 10-page document. It has a lot of good information there, and we do have some quick guides that are hanging in the ED regarding some of our guidelines regarding TBI. But here you can see Tylenol is the first choice. We want to avoid NSAIDs for 48 hours post-injury. And that's, again, if we have not done imaging. We don't know what's going on inside of the brain. So we'll just say avoid NSAIDs for 48 hours. If imaging has been completed and you guys actually do see a bleed, I'm sure trauma or neurosurgery is going to say to avoid NSAIDs for a longer period. But to be safe, we always say avoid them for that first 48 hours. And this is also really important because if you have a kid come into the ED, you guys don't do imaging, he's just saying, okay, probably a concussion, looks good. Still, just remind providers, the BCH-Oakland is, it may have been, thank you. Thank you for noting the typo. Or he may have gotten it actually before, I'm not sure. So anyway, for the Tylenol, don't give it for 48 hours, especially if you're sending them home with concussion. And then also we avoid not giving narcotics or benzos because they can cloud your neuro exam. Okay. So he's then roomed in room 8. He's later, a few minutes, moved to room 5, and he's assigned in acuity 2. So I'm glad that you guys all said you would activate, but this kid hasn't been activated yet. So let's see what's going on. Someone decides he needs a head CT. And in the chat, if you guys can tell me, what tool do we use to determine if we want to get imaging or not? Does anyone know what this little kind of chart is called? Give everyone a few minutes. And it's always okay if you write the wrong answer, but what I'm looking for is what's our sort of clinical decision helper that can see if we needed a image in a TBI patient. Anyone? How did we know we needed the scan? PCARN. So hopefully you guys have seen this before. This is an algorithm. The top half is marked letter A, and this is for children younger than 2 years. The bottom being B, and these are for those who are 2 years and older. So for this kid, he's 12 years old. We'll look at the bottom half. We'll look at B. And here it says GCS is equal to 14, or are there other signs of altered mental status? We know he has lethargy and nausea, so I would say yes. And CT is recommended. So this was a study that says people, who fall into this category, what's the propensity for them to have actual injury on their scans? So that's how this algorithm was created. It's the Applied Research Network. And the other thing that's noted there is, does the patient have signs of basilar skull fracture. This kid doesn't, but I just wanted to briefly go over them and the signs of a basilar skull fracture. Here you get the periorbital ecchymosis. Maybe you guys have seen these. They're the raccoon eyes. Also the battle sign, which is the hematoma behind the ear. If you see any bleeding coming out of the nose or the ears, that's you also worry. So the hemotympanum, this is bleeding that's in the tympanic cavity. Otorrhea or rhinorrhea, that's when you see the bloody discharge mixed with the CSF. So there you may actually see the halo sign once you're using gauze. Okay, so we ordered the head CT, and again, it's a little bit later now. It's an hour and 12 minutes after arrival. He gets Zofran. We know what we talked about in Zofran, that it may mask some symptoms. So what we say in our Oakland TBI guidelines is that Zofran is not recommended during the observation period. So if we were thinking, okay, kid comes in with a concussion, let's give him Zofran and send him home. Like we said, that can potentially, some studies showed yes, some studies showed no. So I do want to acknowledge that it can potentially mask symptoms of nausea. It also showed, some studies showed that there was a higher rate of readmission with patients who got Zofran and were sent home, because then once they got home, they started to show more symptoms of their TBI. Parents would bring them back in. So that's why we say Zofran's not recommended for the concussed patient who is being discharged from the ED without imaging. If you need Zofran course to keep your patient comfortable, consider a CT scan, because then as we see on the PCARN, they're obviously having some symptoms of their TBI. So consider it a CT scan. All right. And we get our CT scan, and of course it shows that we have an epidural. So we have a 2.7 centimeter epidural, and there's a midline shift. And remember, he still hasn't been activated. So ED nurses, you guys are on it. You guys get 2 PIVs. Labs are sent. Lactate is a little bit elevated at 2.4. Someone from radiology calls the ED attending and says, we have a fairly large epidural hematoma. And because he's still having symptoms, he requires a little bit more, and he ends up getting some IV Zofran. Again, this was going to be my poll, and I was going to see, can anyone tell me a kind of classic feature that you hear about in epidural hematomas? Clinically, how they present. I forget the options that I gave, but maybe it was like hyperagitation, a prolonged MPO period, or is it this period of clarity followed by neurologic decline? So Emily, thank you. She says waxing and waning. So yeah, pretty indicative of an epidural hematoma, which we'll talk about when we, yes, thank you, period of lucidity prior to decline. We'll talk about why that is when we talk about some of the anatomy of an epidural. But these are particularly worrisome because they can look really, really great early on. The patients may not have a ton of clinical symptoms, and then they may deteriorate on you all of a sudden. So these are kind of worrisome. So this is this kid's scan. As you can see, I am not a radiologist, so I will describe this in pretty basic terms. I'm hoping that I got this line midline, but as you can see, I'm sure everyone can see, you have this pretty large hematoma, and you can very visibly see this midline shift on both of these. Okay, and then you see this shift. So already just off of imaging, you know that this brain is already under a lot of pressure. All right, and why do we do a CT scan? We have so many other cool imaging. Why do we do a CT scan? Time is the number one thing that I think of. It's quick. Most patients do not require sedation. So you're able to keep your neuro exam because you don't need to give any sedatives. And here at Oakland, our goal is to be out of the trauma bay and to the CT scanner in 15 minutes. This is because time is brain. Once we know what's going on, hopefully we can go to more interventions quicker. The next thing, why do we do non-contrast? Funny is that blood and contrast, they both light up on the CT scanner. So we don't use contrast to evaluate for bleeds. CTs are great for looking at bones or bleeds in the head, not so great for looking at soft tissue or brain tissues. So in that case, if you want to see more tissues, you'll probably get an MRI. If you want to look at nerves, arteries, veins, you'll probably be looking at a CTA. And then the other thing that we preach a lot throughout trauma, and this is not specific just for TBI, CTs have a lot of radiation. And in pediatrics, we know that there's a cumulative effect of radiation. So we don't want to kind of load them up with a ton of radiation early on in their life. There's one trauma surgeon who's out there who says that CT is almost like your primary injury, and your secondary injury down the line will be loads of cancer processes in kids who have gotten radiation early in life. So we definitely want to be mindful of using CT. That's why you'll see follow-up, that a lot of doctors will get MRIs for follow-up scans. This is also why we tell outside hospitals, one, let us do the scan. We'll use pediatric dosing. We won't use adult dosing. And we will really concentrate it to the area that needs to be radiated. I think pan scans are somewhat used widely in adult facilities, but in pediatrics, we don't recommend pan scanning unless absolutely necessary. All right, so now the subdural versus the epidural hematoma. In both of these words, obviously, we see the word dura. So we're looking at this outer gray covering, which is the dura. You guys probably can't see my my mouse going around, but we're looking at this gray outer covering, which is the dura. And the differentiation is whether this is below the dura or outside of the dura. And that really affects which vasculature we're talking about. So if it's subdural, this typically involves the tearing of the bridging veins. Oh, thank you. You can't see my mouse. So it typically involves tearing of the bridging veins. So this may have a little bit later onset. It may take a little bit longer to accumulate in that space because it is venous. And you may see symptoms that are that can be up to 72 hours out. So with the epidural, this is outside of the dura. And because this involves your arteries, the meningeal artery kind of runs right through there, this has a higher propensity for blossoming, getting larger. They can bleed really rapidly. And as you guys already know, it has this transient loss of consciousness followed by a lucid period, and so on and so forth. They can have this lucid period and then also have a neurologic decline. So these are worrisome only because you are dealing with an arterial bleed. And something just recently, this has always kind of been out there. We've just recently added it into our mild TBI guidelines, is because these are so worrisome. We actually do have an epidural observation protocol because we do get kids who are from far away. So if someone comes in, we know that they have an epidural. They may not need surgical evacuation right away, but we want to be sure that we are observing them. So what we recommend is for patients with a driving distance of over 2 hours, we really want to make sure that we're observing them for 72 hours. And if I'm correct, I think this may not have to be inside the hospital at all times. I believe they can be on campus somewhere, but they need to be close by for 72 hours because of this can bleed at any time. Okay, so our patient's still in the ED. We know that he has an epidural. We didn't get trauma involved yet. So someone activates a trauma partial. And now we're starting to see that he's having a little bit more symptoms. His heart rate is dropping a little bit more. Blood pressure is a bit more elevated. His pain, well controlled right now, with pain of 2 out of 10 and still maintaining a GCS of 15. Okay, so the trauma surgeon arrives and calls a trauma full. So he noted that this patient was having declined mental status, which I think was increasing lethargy. They give him some Keppra. Heart rate, vital signs still look the same. So can anyone tell me why we saw declining mental status? Why did he pull a full? Why did we upgrade to a full? Why didn't we keep it a partial? give you guys a few minutes to write in the chat. Yeah, thanks, Heidi. Perfect, thanks, Fran. Yeah, so I'm thinking the trauma surgeon is probably thinking that this kid is gonna go to the OR. So let's get all of our resources on board. And they give him a Keppra load. Well, he didn't have seizures, so why are we giving Keppra? It's one of those neuroprotective agents, which we'll talk about when we go through what all of our agents are. And that's typically because we want to avoid any further injury to this already excitable brain. It's not because he had a seizure, because actually impact seizures are somewhat common, and it doesn't mean that they're going to have seizures for the rest of their life or even have seizures throughout the rest of their course. The reason that we're giving Keppra is to avoid any further insult to an already excitable brain. Okay, and our trauma surgeon decides to give TXA. So we already know that we have bleeding inside of the space, and to avoid those clots from breaking down, he decides to give TXA. And we know we're going to the OR. Next, we give some 3%, so we give some osmotic. His blood pressure's still a bit elevated, pain is still okay, and we're still recording a GCS of 15. I don't know if this is correct. I think I may have scored him a little bit lower, given that we know that he's having a lot of lethargy. So, but according to documentation, he does still look like he's a GCS of 15. So that's what I've noted there. Now he starts throwing up. Okay. Then we give Mannitol, which I hope you guys have possibly heard in some of our lectures. Mannitol is somewhat controversial. We don't like to give it in trauma patients, and I'll talk about that on the next slide. But I do want to point out that this was a collaborative decision by the trauma surgeon and the neurosurgery attending. Okay, so they both got together. They both said, this is a very focal injury. This occurred just to his head. I don't think that there's any injury anywhere else. Trauma surgeon agreed and said, okay, we can give the Mannitol. Our goal is to relieve that pressure, but we also don't want to leave him worse for the wear if we give him Mannitol, and we'll talk about that next. This kid gets some FFP, and the MTP is activated. And I actually think those were the only products that he was given was this, this plasma. And the reason for that is TBI patients typically have what's called a TBI-induced coagulopathy, whereas they're not actively hemorrhaging, so you're not worrying about replacing all of those red blood cells, but more so it's this clotting cascade. It's not fully well-known, understood why it happens in TBI patients, but TBI patients are more coagulopathic rather than actively fully hemorrhaging that you would see in an MTP activation. So we know he's going to the OR, so he gets intubated, gets an OG, and now his GCS is 3T. Thank you to whoever still got the GCS, because as you know, even if your patient is intubated, you can still get a GCS. And here, very quickly, a note on Mannitol, like I was saying. So in traumas, so much is unknown. I have no idea when this kid ate last. Maybe he's been playing baseball in the sun. Maybe he hasn't eaten for 2 days. I don't know which way he's coming in. So if I give Mannitol, there's a potential that I can push him over the edge and he can become hypovolemic. This has actually happened in a case that came in through Oakland, got Mannitol at an outside hospital, and they didn't properly fluid resuscitate him. So this actually can put you well behind the curve, and patients can show up hypovolemic, or we can potentially make them hypovolemic. The other thing is in massive traumas, we worry about this case, he just got a baseball to the head, but otherwise we would worry, maybe they had some abdominal injuries as well. Maybe they're bleeding into their belly. We don't know that yet in the early stages. So that's why we say, let's not give Mannitol, let's stick to 3% for our trauma patients. Okay. And as we said, our goal in TBI is to lower the intracranial pressure. We all saw his scan, we saw that large bleed, and then it was shifting some of the stuff past the midline. In a talk about severe TBI, I'll probably get into these numbers a bit more, but but it's a pretty nice, easy calculation. Your cerebral perfusion pressure, which you can think about as your cerebral blood flow, equals your MAP minus your intracranial pressure. So you want to keep a nice high MAP to ensure that you're having perfusion to the brain. And ideally, you want to keep that ICP low so that, again, it's not compromising, so that, again, you're not having those shifts. And our gold standard, basically everyone's gold standard, is to keep that CPP above 60. ICP should typically below 20. And there's plenty of research that shows increased morbidity and mortality once you get that CPP below 60, or that ICP goes below 22, I believe is the number. So these are pretty significant. All right, and as you guys all said, we were preparing for the OR. 1725, this is around 4 hours after injury. Patient goes to the OR for a craniotomy. And again, this is to relieve the pressure. It's for hematoma evacuation. Because surgery thought he did well intra-op, he doesn't have a drain placed. He goes to the PICU, heart rate getting a little bit better at 75, blood pressure still pretty elevated, I mean, for a 12-year-old. A little bit groggy, GCS of 13. He later goes for that follow-up scan. Again, we've talked about why we don't do a follow-up CT. So he goes for an MRI, and it looks like everything has been appropriately evacuated. Overnight in the PICU, he continues to have a little bit more emesis. Again, probably that excitable brain may still have a little bit of pressure, but we've shown adequate evacuation. So he gets Reglan, he gets Zofran, he's maintained on some IV fluids. Incidentally, on his MRI, they saw that he had a lymphadovenous malformation. It did not contribute to his trauma. It was just another finding. So hospital day 2, once he wakes up the next day, excuse me, he's a little bit sleepy, but he's still answering questions appropriately, still having a little bit of that headache and nausea as residual. We keep him on a 7-day course of Keppra. This is typically determined either by neurology, neurosurgery, or I believe trauma surgery can sometimes order, but it's typically neurosurgery or neurology. And again, that is not because he had a seizure during his case, it's just avoiding further insult. He's able to advance his diet. And then the other thing for TBI is that we hope once they're in the PICU or the ward that the team is getting speech involved to do the cognitive assessment. PT and OT can also evaluate to see if there's any deficits. So hospital day 4, he gets to go home. He doesn't have any neuro deficits, and he follows up with neurosurgery, looks really good from those notes, and then they make a recommendation to go to vascular anomalies clinic for that malformation that was found. All right, so that was our case. It was a pretty straightforward one, but I think hopefully what I highlighted was to get trauma involved a little bit earlier. I don't think he probably should have went through triage, then getting room, then acuity, and then waiting until we got the scan. So maybe activating a little bit earlier, getting that scan a little bit earlier. Some of his early clinical signs that were worrisome, as you guys all pointed out, you guys didn't miss any. It was this nausea, this emesis. He was lethargic. That first set of vital signs, he showed that his heart rate was a little bit low and his blood pressure was starting to creep up. We talked about utilizing PCARN to determine if you want imaging. And hopefully you guys know now that if we're giving Zofran, get a scan, because we may be hiding symptoms, and they may also have that kind of rebound effect if we send them home on a Zofran course. And if you're getting a scan because you're concerned that this patient might have something intracranial going on, involve the trauma team. You guys are all aware of the activation criteria, so seeing where they fall within that. And as we said, primary injury we want to prevent, but secondary injury, that's where we as bedside nurses, that's where we can help with neuroprotective measures. So for here, I know we only have 15 minutes, so I'll go over this more probably if we talk about severe TBI, but even in the mild TBI, there's a lot that we can do. Avoiding that hypermetabolic state. This is, again, avoiding further injury, which you guys have heard me say many times now. This is why we give that Keppra course. And also we want to avoid fevers and pain. Fevers are obviously going to make you, again, that hypermetabolic state. Pain, your body tenses up under a lot of stress. It can drive that ICP up. Normothermia. Throughout the whole severe TBI policy, you'll see the word normo in everything. Previously, there was a period in clinical practice where TBIs were actually cooled, and that was cut short because they were actually having worse outcomes. So now we target normothermia. Hypothermia also can exacerbate the coagulopathy, which we talked about. And then fevers, as you know, raise the metabolic demand. So in the PICU, when you guys are putting them on cooling blankets, warming blankets, hopefully you're setting the goal temp as normothermic. You don't want it to be too cool or too warm. Our main intervention is decreasing ICP, relieving some of that pressure. As we talked about, time is brain. This is why we said, get to the CT scanner in 15 minutes. Let's get interventions going as soon as we know what's going on inside of there. And early surgical intervention if needed. And that was why we pulled the trauma full. We get all of our resources and hopefully go to the OR pretty quickly. Other things that are more, benign that we can do, even if it's not a severe TBI, head of the bed elevation. If they don't have any spinal restrictions, keeping the head midline, keeping the head of the bed elevated, this just promotes drainage. Clustering care, even if you don't have a TBI, no one wants to be messed with, a ton. So keeping all of your care clustered, some brain rest for these kids, avoiding hypoxia, keeping your pulse ox above 95%. As we talked about that cerebral perfusion pressure, we also want to keep the brain oxygenated. Keeping your CO2 levels normal. Again, in a severe TBI talk, we can talk about the effects of CO2 on vasculature, but for here, this kid, he was intubated just for the OR. We didn't really have a way of controlling his CO2 once he was out. We talked about osmotic agents, relieving the pressure, and this is through use of 3% normal saline. And then lastly, correcting a coagulopathy. We don't want to have bleeding brains, so keep them normothermic and then give them, we gave this patient, we gave him TXA and we gave him FFP. All right, and then hopefully you guys are aware of this TBI alert. This lives in the quick guides in the ED because there's a lot of things to remember for a TBI patient, and we realized that. And the physicians were like, this is a ton of stuff to remember. We need just a very quick, informal kind of checklist. So hopefully you guys have seen this on the left side. And it's all the points in which we talked about. 3% instead of Mannitol, TXA for the severe TBI, if it's within 3 hours from the injury. In his case, I think he was a little bit longer than that 3 hours out. Otherwise, you can check a TEG. TEG will tell you if you are having hyperfibrinolysis, in which you would then give the TXA for. But otherwise, you may see some physicians give the TXA earlier on in the course, even if your TEG results have not come back yet. And that's, again, if it's within this 3 hours of injury, this window. The goal time for the CT for the severe TBI patient, 15-minute wheels out. Hopefully you guys have images acquired by 30 minutes. Checking temperatures in and out of the ED, keeping them warm. And the reason that we do in and out, again, like I said in the very beginning of our lecture, the whole goal of a trauma system is to look really, where can we improve our system? Where can we do things better? If we find that, in the ED, these kids are super warm, they're perfect, then they get to CT and now they're really cold. Well, maybe we need to put interventions into CT to keep them warmer, because this kind of cascade can really follow them throughout their admission. If they get cold in the ED, they stay cold in the CT, they're going to arrive to the PICU cold, and then it's really hard to get them back. So early on, all of those interventions are super, super important. This patient did not have a skull fracture, but if he did, and it was an open skull fracture, which means fracture with lacerated skin overlying the fracture, we would have given him antibiotics. We would have given Ancef as soon as possible. The other thing is, if this open skull fracture, or really any open fracture for that matter, if it was dirty, if it was particularly dirty, we'd want to extend the coverage to gentamicin. If there was any fecal contamination, or if this occurred in a barn, like I think this year we had a patient who was kicked in the head by a horse in a barn, then we want to think about extending that coverage even more. We would probably add penicillin. Keppra, loading dose for all severe TBI, and then neurosurgery or neurology will determine if that 7-day course is needed. And again, we talked about patients with these infants with these really large heads and weak necks. So you think about if you need a collar, and it's not just the infants, obviously, if a teen is in a high mechanism or a car accident, you'd also think about a collar. And then on the right side, we stole this graphic from the stroke kind of campaigning when it comes to stroke, time is brain. Same thing for TBI. When it comes to severe TBI, time is brain. We want to get the imagings quickly. We want to get interventions quickly as well. And that's it. So thank you guys for coming to the case review. As we said, trauma, we're always looking for systems improvement. Hopefully, as Fran said, we'll do more kind of case reviews. I'm more than happy to do more NeuroTrauma reviews or severe TBI or brain anatomy or anything like that. I really love this stuff. So if you have any questions, please feel free to reach out to me. My email's there. I made the 3 extra large because I'm also Lauren Williams, I think 1 and 2, because I previously worked here, but they don't go to me anymore. So I'm just Lauren Williams 3. All right.
Great. Thank you, Lauren. So does anyone have any questions for Lauren? It's a quiet crowd this morning.
That's okay. It's early. I was tired as well, and now I've talked a bit too much. So
Every week.